Opioid practice video part 2 of 2. Question 5. Mr. Chan is on oral OxyContin 40 mg BD plus PRN oral endone 10 mg for metastatic lung cancer with bone and adrenal mets. His pain has been progressively increasing over the past 2 months. He now consistently takes PRN oral endone 10 mg 5 times per day. The PRN oral endone helps, but only for about 1 to 2 hours. He is not vomiting or constipated. His renal and liver function are normal. CT shows progression of the metastases in his bones and adrenals. He is admitted to hospital for severe pain. What analgesia would you chart? Make sure your answer includes regular, PRN, and timing of stopping old and starting new analgesia. Answer. There's a few ways you could treat this patient. The first decision to make is whether you want to convert him to regular subcutaneous morphine or regular oral morphine. Both are valid options. An argument for using regular oral analgesia is that he's not vomiting or constipated, so oral route will be fine, and has the advantage that later on, it may be easier for you to convert directly back to long-acting oral analgesia. However, an argument for converting to regular subcut analgesia is that because he's in such significant pain, the subcut morphine will have a faster onset of action, and so any PRNs will get him out of pain faster, and it completely takes out any concern of gut dysfunction out of the equation. My personal preference in these cases of severe pain is usually to use the subcutaneous route. The second decision is what to do with his breakthroughs. Some clinicians will add the regular medications together with breakthrough usage over 24 hours and convert that sum. Other clinicians ignore the breakthrough usage and just convert the regular dose, but increase it by a certain amount, say 25 to 50%, to account for the fact that the regular current dose is not controlling pain adequately. We will demonstrate both these strategies. In the first strategy, where we add together the regular and PRN usage in the past 24 hours and convert it all, we make the following calculations. OxyContin oral 40 mg BD plus PRN oral endone 10 mg times 5 equals 130 mg oral oxycodone over 24 hours. Times 1.5 to get to oral morphine equals 195 mg oral morphine over 24 hours. Divide by 2 to get to subcut morphine equals 97.5 mg subcut morphine over 24 hours, equals 16.25 mg subcut morphine Q4 hour regular. Dose reduced 25% due to opioid switch equals 12.19 mg subcut morphine Q4 hourly regular. Going to round that up to morphine 12.5 mg subcut Q4 hourly plus PRNs. If oral OxyContin slow release was taken at 8 a.m. in the morning, start regular subcut morphine at 8 p.m. and use PRN subcut morphine in the meantime. In the second strategy, where we ignore the PRNs and convert just the regular dose but increase it by a certain amount, say 50% due to his severe pain, we make the following calculations. OxyContin 40 mg BD equals oral oxycodone 80 mg over 24 hours times 1.5 to get to oral morphine equals oral morphine 120 mg over 24 hours. Divide by 2 to get to subcut morphine equals subcut morphine 60 mg over 24 hours. 50% dose increase due to pain equals subcut morphine 90 mg over 24 hours, which is equal to subcut morphine 15 mg Q4 hourly regular plus PRNs with the same timing. So you can see that the different strategies come up with slightly different answers. And I think you're getting the idea now that neither dose is wrong. They're just different ways coming up with equally valid answers which get you in the ballpark of a starting dose, and then it's all about monitoring patient symptoms and side effects to titrate from there. Question 6. Miss Diaz is on 10 mg subcut morphine Q4 hour regular plus PRN 5 to 10 mg subcut morphine Q2 hourly for metastatic colorectal cancer with liver mets. Her pain is under control and you want to switch to oral medication to allow her to be discharged. How would you convert her to oral analgesia so she can go home? Make sure your answer includes regular, PRN, and timing of stopping old and starting new analgesia, and there can be multiple steps in the conversion process. Answer. There are two possible approaches. The first, more traditional method is to convert from regular subcut morphine to regular oral immediate release morphine such as Ordine, titrate to good symptom control, then convert from regular Ordine to regular long-acting oral morphine, for instance MS-Contin. The second method is to convert directly from regular subcut morphine to MS-Contin. Importantly, because both regular Q4 hourly oral morphine and regular MS-Contin will reach a steady state by 24 hours, both can be titrated every 24 hours based on the patient's symptoms. We will demonstrate both methods. Using method 1, as the patient is on 10 mg subcut morphine Q4 hourly plus PRNs, when converting from subcut to oral morphine, we use a 2-to-1 ratio, so I'm going to take a shortcut and just double the dose to get 20 mg oral morphine Q4 hourly regular plus PRNs. Then we titrate according to symptoms. Let's say pain remains good and no further titration is required, then we know 20 mg oral morphine Q4 hourly equals 120 mg oral morphine over 24 hours. So that can be given as oral MS-Contin 60 mg BD plus PRN oral Ordine 10 to 20 mg Q2 hourly, maximum 120 mg per day. Give the first oral MS-Contin dose at the same time as the last immediate release oral morphine dose. Note how no 25% dose reduction is needed because we are not switching from one drug to another, but just from subcutaneous to oral. If we use method 2, where we convert straight from subcut morphine to MS-Contin, 10 mg subcut morphine Q4 hour regular equals 60 mg subcut morphine over 24 hours, times 2 to get to oral morphine equals 120 mg oral morphine over 24 hours, equals MS-Contin oral 60 mg BD plus PRN oral Ordine 10 to 20 mg Q2 hourly. Give the first oral MS-Contin dose at the same time as the last immediate release subcut morphine dose. Question 7. Miss El Arabi is an inpatient on morphine 10 mg subcut Q4 hourly plus PRNs for metastatic colorectal cancer with peritoneal metastases. Her pain is well controlled. She often has intermittent partial bowel obstructions, so you want to switch to a fentanyl patch with the aim for discharge. Which patch strength would you choose? What PRN analgesia would you chart? What's the timing of stopping subcut morphine and starting the fentanyl patch? Answer. Morphine 10 mg subcut Q4 hourly regular equals 60 mg subcut morphine over 24 hours, times 2 to get to oral morphine equals 120 mg oral morphine over 24 hours. But we're going to dose reduce 25% due to opioid switch, equals 90 mg oral morphine over 24 hours. The fentanyl chart is done in relation to Q4 hourly regular oral morphine dose. So 90 mg oral morphine over 24 hours equals 15 mg oral morphine Q4 hourly. Now we can use the fentanyl conversion chart, and 15 mg oral morphine Q4 hourly is equivalent to a 25 microgram per hour fentanyl patch every 3 days. In terms of PRNs, she was on 10 mg subcut Q2 hourly PRN. So I would ask her how effective that was and if it caused any side effects. If it was working well, I would convert it straight to PRN Ordine 10 to 20 mg Q2 hourly, maximum 120 mg per day. If starting the fentanyl patch at 10 a.m., give regular subcut morphine at 10 a.m., 2 p.m., 6 p.m., then cease. In other words, an approximate 12-hour overlap. Question 8. Mr. Lamb has metastatic non-small cell lung cancer with bone and brain metastases. He was admitted for pain control and has been stable on MS-Contin 100 mg BD orally for the last few days. He is planned for discharge tomorrow but becomes increasingly drowsy and can no longer take oral medications. You request a set of observations and review him. Would you suspect severe opioid toxicity and use naloxone in any of the following situations? A. Respiratory rate 20, SATs 88%, temperature 38, heart rate 120, blood pressure 100 on 70, drowsy but rousable. B. Respiratory rate 12, saturations 100%, temperature 37, heart rate 80, blood pressure 130 on 80, unrousable. C. Respiratory rate 7, saturations 89%, temperature 37.2, heart rate 95, blood pressure 110 on 75, drowsy but rousable. Or D. Respiratory rate 24, saturations 85%, temperature 37.2, heart rate 110, blood pressure 90 on 60, drowsy but rousable. Answer: only scenario C is compatible with severe opioid toxicity. Severe opioid toxicity can be suspected if the respiratory rate is less than 8 breaths per minute and either the patient is drowsy or unrousable, oxygen saturation is less than 85%, or patient is cyanosed. If respiratory rate is normal or high, by definition, the patient does not have opioid-induced respiratory depression and therefore does not require naloxone. Scenario A is most suspicious for pneumonia, Scenario B of intracerebral bleed, and Scenario D of pulmonary embolus, all of which can make a patient drowsy. Scenario C is consistent with opioid-induced respiratory depression, so this patient needs naloxone. The next question is why, as the patient was stable on MS Content 100 mg BD prior to this episode. Possibilities are drug error and unexpected renal failure, so EUCs need to be checked, along with the workup for other reversible causes of drowsiness. Final reminders. We are trying to teach you one out of a variety of possible methods to prescribe opiates. These opioid conversions always only guide you on the initial conversion. After the initial conversion, it is all about listening carefully to the patient and/or carers to know how to adjust from there. Thank you for your patience and effort to go through this training.